No. I'm going to turn over to Dr. Michael McKee, who's going to moderate there's going to be 4 presentations by 3 interns, and then I think a 5-minute summary of some other things. There'll be time for questions, I believe, after each presentation, which will be 15 minutes plus 5 minutes for questions. So we're probably going to have to watch the clock very closely. Okay, thanks. And take it away, Mike.
Thank you so much. So I'm excited to present the MDisability Summer Internship presentation. We do this once a year. And just for those of you who are not aware, MDisability is a disability health program within our department. We have this infographic up here. It's an updated infographic. What we're trying to do is really move the needle with primary care to be able to care for these people in a more person-centered way. We have several projects within disability health, and that's actually medical education, research, community partnerships, adaptive sports. So there's a lot of exciting things happening and taking place within MDisability. Before I introduce the presenters, this is actually has not come about without the support and effort of many of us here. So I want to acknowledge and thank Dawn Michaels for all of her hard work on not only just arranging and supporting the summer internship program, but also doing a lot of the behind the scenes work. And for the summer internship, we had many presenters participate. And so I want to thank every one of you for actually taking the time out of your day and also having an opportunity to talk to the summer interns. And a big thank you for the mentors. So Fermi and Elham, I want to thank you for spending the time mentoring our summer interns as well. So, and again, thank you for everybody not only supporting in many ways, whether it's research, funding, and or just words of acknowledgement and support. So thank you, everyone. So we have 3 presenters, and so 3 summer interns. The summer internship program is really an opportunity for those who are either an undergrad or just recently moved into a graduate level, interested in disability health, want to pursue a career in that as well. And what we're trying to do is really advance the number of researchers, clinicians, community partners that are in the field of disability health. So this is a great pipeline to allow people to go out and do great work. So the first presenter we have coming up is Dana Chung. I want to also congratulate her. She just got into medical school here at University of Michigan Medical School. So big kudos to her. So she is actually already a medical student, but she has already taken a little bit of time to share her work. So let's start with her and I'll present the other 2 presenters. Thank you so much. Let me stop sharing. Hey, Dana, it's all yours.
Hi, everyone. Thank you for the introduction, Dr. McKee. As Dr. McKee mentioned, my name is Dana. I'm one of the disability interns this summer. Just for some background, I just started my first year of medical school at the University of Michigan after completing a post-bac program. I was a career changer. I worked in Boston for 2 years doing health analytics for large healthcare companies that have been sued. And the role I was doing is in consulting. So this summer, I was very fortunate to be able to work with Dr. Mahmoudi on several of her projects and be involved in this internship. Today, I'll be taking time to present the initial results for a study on traumatic spinal cord injury and the initial research plan for a study on the home care at home program implemented at Michigan Medicine. To start off with, we'll be just talking about and spending most of our time talking about the results of this first study, traumatic spinal cord injury and the risks of early and late onset Alzheimer's disease and related dementia. Just due to the limited time and the 2 other presenters, I would please ask that any questions be put in the chat. I'm hoping to get to them at the end of the presentation, but I know that we have limited time and a lot to go over with the other presenters in the group project that we worked on. So let me just advance. Okay. To start off with some background information, traumatic spinal cord injuries are mostly caused by motor vehicle accidents, falls, or active violence. Traumatic spinal cord injury is a clearly a life-altering event that often causes permanent physical disability. And there is some evidence that traumatic spinal cord injury may exacerbate certain biological mechanisms due to neuronal damage that might elevate the risk for dementia. I won't go into a lot of detail, but the figure on the right illustrates how inflammation or apoptosis or other sort of processes can lead to changes in neuronal function, which was the basis for our project. And then moving on to a brief background on dementia. For the purposes of this project, we'll be really referring to Alzheimer's disease and related dementia as simply dementia. The greatest known risk factor for dementia is increasing age. Additionally, several studies have shown that many chronic conditions are also associated with increased risks of dementia. These conditions include diabetes, hypertension, cardiovascular conditions, depression, sleep disorders, etc. Again, I won't go into as much detail, but on the actual mechanism, but diabetes is associated, for example, with an increased risk of dementia due to the direct disruptive effect of amyloid beta peptide clearance. And through these different processes related dementia, where these patients are at higher risk for dementia. There are also several classes of medications that can be used to treat these chronic conditions that studies have shown may also increase dementia risk. For example, studies have shown that anticholinergic drugs block neurotransmitter activity, linking to long-term cognitive decline or dementia due to changes in glucose metabolism and brain atrophy. So that's just some background on traumatic spinal cord injury and dementia. And moving on to this actual study, we were looking at and we were looking to expand upon a previous study that was completed by Dr. Mahmoudi and her team. It was determined that in this previous study that was published in 2021, that the risk of dementia was higher among adults with traumatic spinal cord injury compared to the matched cohorts of adults without traumatic spinal cord injury. And in order to address the shortcomings of the prior work, we really wanted to work on incorporating compounding factors of dementia risk, which are prior chronic conditions and prolonged medication use. Additionally, the process in which the patient data was used or was selected in the previous study was refined and updated. The study identifies patients through incidence of traumatic spinal cord injury or diagnosis during hospital admission, which limits our sample size for thorough evaluation of dementia risk before and after incidence of traumatic spinal cord injury. So for a brief overview of the methods, for this study, we used private administrative claims data from Optum Insight. This data ranged from 2010 to 2020, and we identified 657 adults with incident traumatic spinal cord injury. A panel of experts were used to categorize and identify these cases. For our control data set, we identified over 4 million adults without traumatic spinal cord injury throughout the entire enrollment period. So for our initial patient population, we matched adults with incident traumatic spinal cord injury to adults without a diagnosis of traumatic spinal cord injury on age, sex, chronic conditions. Patients were matched 1 to 10-fold in order to have a robust sample size. And just from a brief overview of demographics, 69% of the patients with traumatic spinal cord injuries were 65 years and older. 46% of patients with traumatic spinal cord injury were women, whereas 54% of patients without traumatic spinal cord injury were women. So this is a stacked bar chart here that is showing the incidence of dementia among individuals with and without traumatic spinal cord injury after 6 years. After year 1, which is the darkest blue, I think you can see here, the darkest blue below, you can see that 7.5% of adults with traumatic spinal cord injury developed dementia, whereas in our control group, only 2.1% of adults without traumatic spinal cord injury developed dementia. And as time goes on, in the lighter colors of blue, we'll see that after 6 years, 18.7% of adults with traumatic spinal cord injury have been shown to develop dementia, whereas only 12.1% of adults without traumatic spinal cord injury develop dementia. So this next table here shows the prescription rates for the following 6 classes of medications over 7 years. The 6 classes of medications were anticholinergics, antidepressants, antispasmodics, benzos, neuropathic medications, and opiates/narcotics. And as you can see on this timeline, we are tracking prescription rate from 1 year prior to index of admission and up to 6 years after. So you can see on the left here that the prescription rate for almost all of the classes of medications for individuals with traumatic spinal cord injury increased after the index of admission. And interestingly enough, these prescription rates almost returned back to baseline after over the course of the 6 years. And the only exception to this, which is of note, is the neuropathic medications, which is in purple. But as you can see, even though there's a spike, for example, in opioid narcotics, which is this green line here, the line returns almost back to baseline over the course of 6 years. And on the chart on the right, you can see that the prescription rate for the controls, as expected, is pretty steady throughout the entire 7-year period. But yeah, moving on to this next result, we have this KM curve, Kaplan-Meier curve of a matched cohort of adults with and without traumatic spinal cord injury for dementia survival. Please note that this x-axis should actually be measured at months, not days. And we can see that the survival probability is graphed out over 6 years of follow-up. And this curve shows us that after 6 months, we see a divergence in dementia risk for between the cases and controls. And almost by the end of the 6-year period, we see that the divergence has increased drastically, or increased a fair amount, to the point where 19% of adults with traumatic spinal cord injury versus roughly 10% of the adults without traumatic spinal cord injury develop dementia. So that the survival or the risk in which an individual would be diagnosed with dementia is increasing as time goes on, and if you were to be diagnosed with traumatic spinal cord injuries. Okay, so these 2 tables here show the final initial results of our final step of our analysis. We ran a model that added variables as potential co-founders. So we wanted to look at chronic conditions or medications that may have caused or may have been associated with the risk of dementia. So we wanted to determine that the chronic conditions or medications did not take away from the association of traumatic spinal cord injury and dementia. And as you can see here from the hazard ratios, even after accounting for these conditions or medications, individuals with traumatic spinal cord injuries are still at higher risk of developing dementia, even with these, even when accounting for these conditions or medications. So for example, if a high-end user of anticholinergics were studied and accounted for, there's almost still double the risk of an adult that would develop dementia, despite the fact that they are taking these medications for a long period of time. So this last table is just looking at the age groups. So for example, we adjusted the predicted values of our model to show interactions between traumatic spinal cord injury and age categories. And of note, for early onset dementia patients 45 to 65 years of age, there's almost a 4 times higher risk of developing dementia for adults with traumatic spinal cord injury. And this is particularly of note because similar studies or previous studies have determined similar rates of risk for early onset dementia for patients with multiple sclerosis and cerebral palsy. And it's something that there's interesting links there that should be studied further. So just to summarize, these are the initial results of the study that we were working on this summer. We currently have a draft of manuscript completed and in the process of review and hopefully submission at a journal by the end of the summer. To summarize, the study used a large national private claims data set to examine the risk of or the hazard of traumatic spinal cord injury in association with an association with dementia. Further efforts ought to be made to improve screening, early interventions, et cetera, for this patient cohort. And hopefully this study can identify those interventions that could be implemented to improve the hazard rate risks. We acknowledge that the study has several limitations. Our analysis was limited by certain aspects of the Optum's claims data set. For example, inpatient prescriptions are not included in the claims data. We only have 6 years of follow-up, et cetera. Our results may have been influenced by dementia because dementia oftentimes takes 10 to 15 years to develop. So we hope to continue our studies and make further efforts to learn more about this topic. So that concludes my the first project that we wanted to discuss. I know that we have limited time, and quickly, I just wanted to give a brief overview of the second project that we worked on in Michigan, looking at Michigan Medicine's Care at Home program. So during the COVID-19 pandemic, Michigan Medicine implemented a Care at Home program to provide hospital care at home via remote patient monitoring. This program relies heavily on technology, which is oftentimes a barrier for success among elderly patients. And as a result, we wanted to take a look at the data to see how effective this program is in actually reducing emergency visits and hospital readmission, but also to see how effective it is for use among elderly patients, since oftentimes either cognitive decline or just unfamiliarity with the actual technology is a barrier for success or for barrier for successful use. So we plan to, like I said, look at the efficacy of the program. We plan to address gaps in the literature that surrounds adults with cognitive decline and the success of these programs. These programs have been successful in other countries and other healthcare institutions in the US. And since Michigan Medicine is rapidly expanding the Care at Home program, we look forward to looking at these results. Unfortunately, we had a little bit of a data delay, but results will be completed and shared within the next few months. And this is just a brief overview of the research plan, but EMR electronic medical records will be used, and information on age and sex and hospitalizations and emergency visits will be used to conduct a mixed method approach. So finally, I just wanted to say a big thank you to Dr. Mahmoudi and Dawn and Dr. McKee and everyone who is involved in helping run this disability internship this summer. I had a great experience working on these projects and getting to know each of the faculty members and through the faculty series and working with the other interns. And we'll be talking about a group project after the other two presentations, but please let me know if you have any questions and I'll get to them in the chat because I think I went over time. But thank you.
Thank you so much, Dana. Great work. There are a lot of questions based on I think more on your first presentation. So if you can answer and respond in the chat, that'd be great. So thank you again to both of you, Dr. Mahmoudi and also Dana. Excellent work. So the second presenter I'm going to introduce is Sydney Kesper. She is a rising senior at Murray State. She is also an avid athlete, has a whole bunch of different sports that she participates in. And the mentor is Dr. O. So thank you to Dr. O for being involved. So Sydney, I'm not sure. Do it. Sorry, I'm just kind of scrolling, making sure Sydney's. Oh, there you are. Okay. So go ahead. If you could go ahead, share your screen and go ahead and get started. Thank you so much.
Thank you, Dr. McKee. Like Dr. McKee said, my name is Sydney Kessler, and today the presentation that I'm doing is Prescription to Play, Connecting Individuals Living with Spinal Cord Injury to Local Adaptive Sports and Fitness Resources. Here's a brief overview of the presentation. So we'll start out with background and then move to the rationale, then to the initiative, and then finally to future work and significance. Overall, after the American with Disabilities Act of 1990, significant progress has been made for people with disabilities. However, there are still disparities that remain. For instance, societal beliefs and attitudes regarding disability can sometimes place limits on their abilities, and there are disparities in the opportunities available to these individuals. And so both of these have an impact on quality of life. And one aspect of this is in regards to physical activity. So to look at a subgroup, 50% of individuals with spinal cord injury or SCI report being physically inactive. And the question becomes why? In general, individuals with SCI experience several barriers to physical activity, and they can be categorized as physical, psychosocial, and environmental barriers. So physical barriers may include items like temperature or blood pressure control or the use of a wheelchair for a sport. Psychosocial barriers may be that an individual fears participation in a sport, even if they had participated prior to their injury. And lastly, environmental barriers such as cost or the cost of adaptive sports of equipment can prevent their access. And so all of these combined result in individuals with SCI missing out on opportunities to participate in adaptive sports and fitness. And this is often seen after being discharged from inpatient rehabilitation. So to bridge this gap, RX to Play aims to connect individuals living with SCI to local adaptive sports and fitness resources to increase the awareness of, access to, and participation in physical activity. And so RX to Play is a grant funded by the Craig H. Nielsen Foundation and includes three main components, which are the awareness campaign, demonstrations and events, and monitoring and evaluation. First, the awareness campaign is comprised of two main aspects, and the first is making the connections. And so to lead this component, Chuck Aoki, who happens to be a decorated Paralympian, was hired as the Community Access Navigator, and I served as the Assistant Community Access Navigator. And so in the months of June and July, Chuck and I had 10 initial meetings with various individuals and organizations, a couple of which are shown on the bottom of the screen and include the Dexter Wellness Center, UMaze, and the Disability Network of Eastern Michigan. And so with each of these meetings, our primary goal was to establish that point of connection between RX to Play and their organization, in addition to both entities sharing existing opportunities for individuals with spinal cord injuries. And so after each meeting, we sent follow-up emails and presented each organization with various materials and resources. A couple of items that were presented were a one-page flyer and a list of adaptive sports and fitness resources in the area, in the Ann Arbor and Southeastern Michigan area. For the one-page flyer, it is shown on the right side of the screen, and it includes information about RX to Play, the goals, what it provides, and about the current programming. And so with this, the overall goal was to increase awareness and knowledge in addition to providing direct opportunities for involvement. So in regards to providing direct opportunities for involvement, RX to Play aims to, or hopes to have hopes to allow for free access to adaptive sports and fitness equipment and activities. And so currently this involves our drop-in programming, where individuals with disabilities and without disabilities can participate in a sport in a low pressure environment, and it gives them an overall sense of community. And so for individuals with a spinal cord injury, this sense of community allows them to reestablish contact with the world at large. As one article stated, that individuals get to have connections with others that are in shared experiences and have similar circumstances. And so this statement kind of speaks to the broader impact that RX to Play hopes to have, but we wanted to be able to measure that. And so that leads to the third component of this initiative, which is the monitoring and evaluation. And so for this aspect, we define 3 general areas of interest, which are awareness or knowledge, access, and participation. And all of these are in regards to adaptive sports and fitness. We then define 2 target populations, which are individuals with spinal cord injuries and healthcare professionals. And then we defined a geographic location, which is the southeastern Michigan area. And so after each of these sections were defined, we then developed a more in-depth framework. So this table outlines the methodology, and in the right column there, it's the target populations again, so practitioners or healthcare professionals, and participants or the individuals with SCI. And then each row of the table indicates a separate phase. So currently we are in the initial phase of this process, where we are collecting contact information along with demographic information. So demographic information for practitioners, for instance, may include job title, years of experience, and years of experience working with individuals with spinal cord injury. For participants, this may include items like level of injury and mode of mobility. And so with this, we are collecting this information mostly through a QR code or a paper form if needed, but this is being collected during the initial meetings and events that we're having. And so the contact information that's collected initially will then be used in 3 to 6 months post their initial interaction. And we aim to collect more close-ended information, such as, does education about adaptive sports and fitness result in an increase in knowledge for individuals with spinal cord injury? And so again, like the initial phase, this is going to be collected via a Qualtrics survey. And lastly, we are collecting information through focus groups or interviews, and this is going to aim at collecting more open-ended information. For instance, does education about adaptive sports and fitness and participation in these activities lead to a greater sense of community for individuals with spinal cord injury? And so again, these are going to be collected in April to June of 2023 through focus groups or interviews. And so as the last slide indicated, this grant is still ongoing and we're just in the initial stages. So the funding through the Nelson Foundation extends through October of 2023. And in the coming months, we plan to do more formal presentations to the individuals that we've had initial meetings with. We plan to have expos and demonstrations where individuals with and without disabilities can try adaptive sports equipment. And we also plan to have more events. For instance, the Wolverine Open is going to happen in a couple of weeks, and it's a tennis clinic and a tennis tournament that's open for individuals to participate. And lastly, to speak to the broader significance of RX to Play, the data collected and the programs initiated can contribute to Michigan Medicine to the justification of Michigan Medicine being a SCI model system, where their goal is to collect and gather data to improve healthcare outcomes and care for individuals with spinal cord injury. And so with that, I just want to extend a thank you to the MDisability faculty, in particular my mentor, Dr. O, to those within Michigan Medicine, some of which we had faculty series with, to the adaptive sports and fitness program that I worked closely with throughout this internship. And lastly, to my co-interns, Dana and Sanjana. Just want to say a thank you to everyone. And with that, I believe we're running short on time, so I'm open to questions in the chat, and my contact information is shown on the right side of the screen.
Thank you so much, Sydney. It's exciting to see this take place, and I also look forward to having this be a resource available for all of us to share further. So we have to collectively work on that. So it's exciting to see that. And then I want to move on to our final presenter, Sanjana Radhakonda. She is going to share now elements of disability health education, what's available. So Sanjana, okay, there you are. Okay, you want to go ahead, start? And also she recently graduated from Boston University and is hoping to stay on with us for a gap year in research as well. So thank you so much.
All right. Hello, everybody. My name is Sanjana Radhakonda, and today I will be talking about my MDisability internship project, which was focused on examining disability health curriculum within medical education. Here is a brief overlook of what we're going to be covering today. I wanted to begin by giving some context and background on disability, both in general and as it applies to healthcare. 1 in 4 adults in the United States report having a disability, and that includes physical, intellectual, and sensory disabilities, along with a few others. Although disability is increasingly common across patient populations, it has a much higher prevalence in certain demographic populations, such as the elderly, in women, and in the southern region of the United States. I want to direct your attention towards the graphic on the left, which contains some really startling statistics regarding the barriers to accessing healthcare. People with disabilities face many challenges in receiving accessible healthcare, including communication breakdowns, inadequate accommodations, a lack of healthcare training surrounding disability health, inability to find culturally competent and disability competent providers, as well as general stigma surrounding disability. Furthermore, these challenges often lead to poor patient experiences as well as poor health outcomes, as shown on the graphic on the right, which depicts an increase in the prevalence of chronic diseases when comparing patient populations of those with disabilities and those without. As we know, type 2 diseases are health risk factors that often result in downstream health effects, causing these patients to ultimately require a higher level of interaction within the healthcare system. Ultimately, the lack of accessibility plays a role in their journey to receiving effective healthcare. Unfortunately, it becomes a cycle that is difficult to break because you have patients' needs in regards to accessibility and accommodations, as well as receiving specialized healthcare. They're not getting met, which places them at a higher risk of developing non-communicable diseases. And in turn, the effects of those illnesses require greater access to healthcare, in which, once again, they're faced with the same challenges. Unfortunately, many in the healthcare field hold ableist viewpoints, both consciously and unconsciously. These negative perceptions of disability can lead to health disparities for this patient population. Dr. Lisa Iazzoni published a paper just last year entitled "Physicians' Perceptions of People with Disability and Their Healthcare." Her research team conducted a study on physicians across the nation to assess their perspectives and perceptions regarding patients with disability and their comfort level in treating this population, along with many other factors. Some of her findings are shown above and are representative of the current state of disability health awareness. One of her findings that I would especially like to highlight is that only 40.7% of physicians were confident in their ability to provide equal quality care to patients with disabilities. The disparities in access and outcome are linked with inadequate knowledge and skills of healthcare providers and outline the need for better training and education. The current gaps in training lower provider confidence around disability health, which often leads to many misunderstood legal responsibilities regarding the ADA, increased ableist attitudes, inadequate care for patients, and a reduced provider-patient trust and relationship quality. Our current medical education curricula places an emphasis on viewing disability through the lens of the medical model rather than through the social or wellness model of disability. Take, for example, a wheelchair user is trying to access a building with stairs but no ramp. Through the medical model, this individual's difficulty with entering the building is due to their mobility impairment, whereas the social model attributes it to the environment lacking a ramp. The way we describe and discuss disability affects the way people view disability and their perspectives on it. This translates to the healthcare environment where there are these negative beliefs and ideas surrounding disability can be further perpetuated simply through interactions with our coworkers. But ultimately, these viewpoints can impact patient interactions and influence the care that is delivered. Next, I'll be covering disability health education programs that are currently in place at medical institutions in the country. I'll be listing a couple of different example programs for each of these 6 categories. And although they're not an exhaustive list, these are a few that we decided to include in our paper that is currently being revised to submit to a journal. First, we'll begin with language and humanities-based electives. These courses provide students with an understanding of culture, language, and community of different patient populations. The Deaf Health Pathway at the University of Rochester contains an extensive curriculum composed of a variety of courses for medical students to gain experience interacting with deaf and hard of hearing individuals and to learn about deaf culture. Here at the University of Michigan, we're actually in our second year of offering the American Sign Language elective, where students not only learn the language and culture, but they also gain exposure to communication barriers that deaf and hard of hearing individuals face. Clinical rotations provide medical students with the opportunity to work with providers and interact with patients with disabilities in a clinical setting. Here at the University of Michigan, we have a very interesting program, the Disability Health Elective, which allows students to work with different clinics and different providers across disciplines and specialties, all of whom have a focus on providing care to different patient populations with disabilities. Role reversal exercises are simulated exercises that promote awareness and cultural competency. Students navigate patient experiences through the eyes of a deaf and hard of hearing individual. The Deaf Strong Hospital program at Rochester administers this role reversal exercises for all of their first-year medical students. And although role reversal exercises can help medical students understand the perspectives and experiences of people with disabilities, these exercises, if they aren't done correctly, can be counterproductive. The simulations can promote distrust surrounding having a disability, and participants in these simulations may judge themselves as less than competent or unable to provide care and express more pity for people with disabilities. That being said, with proper guidance, these simulations can be effective in improving attitudes towards living life with disability. Through interdisciplinary coursework, students engage and learn from patients with disabilities and experts. This training for students can change health professionals' attitudes and bias towards people with disability. An increasing amount of institutions are implementing interdisciplinary training in order to bring different perspectives together to improve students' knowledge and understanding of disability. Didactics and simulated patients provide students with a general overview of disability health topics in order to reduce stigma and improve comfort around patients with disabilities. Dr. Sandra Hearn's interactive video lecture series provides an overview of disability and is hoping to promote awareness for first and second year medical students here at Michigan. And it has been shown to increase comfort levels for students in regards to approaching individuals with disabilities. And lastly, we have longitudinal disability health education models, which involve both required and elective curricula, as well as extracurricular activities to help improve patient care for people with disabilities. Programs like the Next Gen curriculum contain a multi-phase approach that spans across 4 years and allows for continued engagement with disability health for medical students throughout their time in medical school. All right, so next we're going to shift toward discussing research and data on disability health. Our current methods of measuring data typically fall within one of these categories. Most often, we utilize a pre and post survey that'll be conducted using any number of scales. Some of them are shown on the slide above that measure confidence and competency, awareness, and/or attitudes and perceptions. The patient communication confidence scale and clinical skills confidence scale are utilized to measure provider confidence with regards to different facets of patient care, such as communication and clinical skills, respectively. These skills can not only be used to, these scales can not only be used to identify gaps in training, but at the same time, they do have the ability to link confidence and communication, as well as in clinical skills, with outcomes. Second, we have the DAP scale, which measures, and as represented by its name, awareness, but more specifically, the effectiveness of disability awareness programs. However, this scale has not been frequently utilized in research, and I believe it's due to its very specific nature that makes it very difficult to adapt to other research. And lastly, we have attitudes and perceptions, which are very commonly measured when evaluating the effects of disability health education and implementation. In fact, changes in attitudes and perceptions were a component of the evaluation data obtained from students who have taken the disability health elective here at Michigan. While the ATDP and SADP are focused on attitudes towards people with disability in general, the community living attitude scale is specific to individuals with intellectual disabilities. The limitations in disability health education research typically fall within two areas, in that current research regarding implementation of disability health curriculum focuses solely on measuring provider improvement in regards to competency, awareness, any of the other skills that we showed on the previous slide. However, we haven't really seen the connection between disability health education and patient outcomes due to the fact that it's difficult to measure and there hasn't been enough research done in this area. Lastly, I want to touch on the future direction of disability health education. There's two major avenues to focus on. One, making medical education more inclusive. We need to increase representation of individuals with disability in healthcare and empower providers both with and without disability to become advocates for patients with disabilities. Next, it's critical that we involve people with disabilities throughout the process of developing and teaching disability health curricula. This comes back to the phrase of nothing about us without us. By incorporating people with disabilities in our process of teaching about disability health, they can provide vital experiences, not only in regards to their own disability, but also provide a lens into intersectionality factors. And lastly, to integrate disability health into objective examinations, including structured clinical exams, board exam questions, and licensure requirements. The second focus is on research and training. Incorporating disability health education and training in residency ensures that these topics are discussed and taught beyond the 4 years of medical education. And ultimately, we need more research focused on understanding and identifying the connection between disability health education and its downstream effects on patient experience, patient satisfaction, and outcomes. I want to thank the entire MDisability team and Dawn Michael for putting together such an amazing internship experience. I had a wonderful time doing this internship. And lastly, I'd really like to thank my mentor, Dr. McKee, who I've had the pleasure of working with and I am learning from these last 9 weeks. Thank you so much for everything you've taught me and your mentorship. I know we're running a little short on time, so if there are any questions, I'm happy to answer them in the chat. And I can also answer them via email.
Thank you so much, Sanjana. So again, it's so exciting to see the different types of work that are taking place here at the MDisability Summer Internship. If we can just perhaps respond to questions on the chat, that'd be great. I know we have a few more minutes, and we're going to go on into the group projects. I actually don't know who's going to start first. That part I don't have. Anybody want to start? Okay, Cindy. Okay.
Let's see, Sanjana, can you share your screen?
Sure, one sec.
Sorry, is anybody going to be uploading the screen?
Yeah, sorry, it's just loading.
Okay.
Yeah, I got the little circle.
Yeah, I didn't know who was going first. All right, awesome.
Here, I can share my screen, Sanjana, if it's taking a minute.
Yeah, would you mind?
Yeah, mine's taking a long time too. Okay, we can go to the next slide. So each of us had are going to be presenting a group project that we all collectively worked on together. So I'm going to be talking about our work with the Ann Arbor Center for Independent Living and their summer celebration for the ADA. So they put on this celebration each year, and for our work, we worked with the fundraising aspect. And so between the 3 of us, we contacted 25 different organizations and built out a spreadsheet that's shown on the screen and listed their name and just various information along with just their level of sponsorship that they would want to do or any donations. And then with each entity that responded that they would donate or sponsor, we followed up with them through email. And so Dana is going to talk about our second group project.
So for our second group project, we were all inspired by the work and passion that went into developing the disability health elective offered to 3rd and 4th year medical students at the med school at U of M. And Sanjana briefly talked about it in her project, but basically the disability health elective is a 2-week course designed for 3rd and 4th year medical students, designed to give students experience treating and caring for patients with disabilities. So students rotate among the different clinics, specializing in disability-based care and introduced to different elements of disability theory, clinical practice, disability law, policy, et cetera. So for our project, we are working on completing a perspective piece for publication at a med ed or curricular development journal. And we are working on looking at the results of the study, or the results of the pre and post surveys that were given to 6 different students regarding the attitudes towards patients with disabilities. And you can see here on the slide, here are some aggregated results showing that particular question stems and the differences in attitudes before and after the elective. The green color indicates that there's a change in score and an increase in agreement towards the statement. So for example, having a disability can make someone a stronger person. Over time, there was a slight increase in score. So although our sample size is too low to run statistical analysis, we are working on adding additional information by sending questionnaires and testimonies to different students and providers involved in the elective. So we are in the process of finalizing these testimonies and are drafting this manuscript, and hopefully we'll have it completed by the end of the internship this week. We also hope to form an infographic just so that information about this elective can be easily shared among internally, but also across institutions that might want to implement a similar elective.
And lastly, I want to talk about MDisability resource page. One of the MDisability initiatives is to build out resources for patients, providers, and medical students. This summer, the MDisability interns put together a robust list of resources for these 3 groups in regards to the topics on the right. We're currently in the process of uploading them all and hope to have it done by the end of this week. But we do have our COVID-19 resource page up and it's available for use. Our main goal was not only to have these resources available, but also make it easier for our users to navigate. I encourage you all to take a look at the MDisability resource page, especially once it is fully built out. I think it'll be a great resource for providers, but as well as for patients and medical students.
Great. I think that was everything. Thank you so much to everyone who helped make this internship a great and positive experience. I'm just going to put in the chat a link to the resource website so that people could take a look at their own time. But if anyone has any questions, I think we have a few minutes.
And while we're waiting for questions that may surface, I just want to thank all 3 of our interns. It was truly a pleasure working with you throughout the entire internship. Your contributions to MDisability through these group projects is extremely appreciated, as well as to the ongoing efforts in disability health and inclusion. And I also want to let everybody know that the 3 interns wrapping up this week mark our 4th cohort of MDisability interns. And this is our 4th internship program. We now have 13 in MDisability alumni, intern alumni, who have gone through our program. And when our website is completed, which we're hoping will be the end of August, there will be a new MDisability internship section on the website in which we will have a whole entire list of all of the alumni. The purpose, in addition to all of this fabulous work, is to create a network for future disability health researchers and health providers. And thank you for this, and to all the faculty who contributed to the program this year.
Don, I also want to mention that I'm very grateful because they are great scholars. I keep working with Sanja's sister, Samantha, during her summer break this summer on a project, and she's fabulous. You guys are all doing a great job. Just want to voice that.
That's awesome. Thank you, Alham.
It doesn't look like there's any more active questions out there. So I guess at this point, it's our time to adjourn anyways. We're at time. Thanks, everybody. This is so impressive. So many great presentations today, and we really appreciate your important work. Thanks.